देश के महानगरों से गांवों तक, यूनाइटेड स्टेट ऑफ अमेरिका से यूनाइटेड किंगडम तक, कनाडा से ऑस्ट्रेलिया तक अपनी कला, विज्ञान, मेहनत, लगन और समर्पण का लोहा मनवा रहे हैं। इसी धरती ने कृषि और मजदूरी के लिए लौह भुजाओं को बनाया। लौह भुजाओं से रोबोटिक कैंसर सर्जरी करने की नरम उंगलियों तक बनाया। आईएएस आईपीएस की प्रशासनिक समझ से राजनीतिक गलियारों तक अपने सुपुत्रों को भेजा। फिल्म, कला, गायकी, नृत्य के लिए भी उर्वरक है ये धरती। जो आदिकाल से लेकर वर्तमान काल तक विद्यमान है। आदिकाल के आरंभ में देव है इसका प्रमाण। जो आदिकाल से लेकर वर्तमान काल तक विद्यमान है। आदिकाल के आरंभ में देव है इसका प्रमाण।
Check, check, check. One. Check, check. 1, 2. Check, check. 1, 2. Check, check. 1, 2. Check. Check. 1, 2. Check. Check. 1, 2. Check. Check. 1, 2. Check. Check. 1, 2.
महिला सशक्तिकरण का विश्वव्यापी संघर्ष चल रहा है। बिहार में चिरकाल से ये परंपरा का हिस्सा है। त्रेता काल में पति की अनुपस्थिति में सीता ने ससुर दशरथ का किया था संस्कार। नगरवधु आम्रपाली के प्रश्न से निरुत्तर होकर बुद्ध ने खोला था बौद्ध धर्म का द्वार। 16 शिष्याएं थी महावीर की। सिख धर्म के 10वें और
गुड मॉर्निंग,
गुरु गोविंद सिंह
नमस्कार।
खालसा पंथ का जन्म
जो भी बाहर खड़े हैं प्लीज अंदर आ जाएं। ऑल प्लीज कम इनसाइड, वी आर गोइंग टू स्टार्ट द सेशन।
विदेशी धर्मों को भी अपनाया। पटना में तो पौराणिक और उत्कृष्ट विश्वविद्यालय नालंदा संस्कारी युक्त शिक्षा पर बल आएगा। शिक्षक और छात्र का अद्भुत अनुपात जिसकी बात आज पूरा विश्व करता है। तब भी यहाँ पे 5 छात्रों पे 1 शिक्षक उपलब्ध हुआ करते थे। यही अनुपात विक्रमशिला विश्वविद्यालय में 10 छात्रों पे 1 शिक्षक का था। वाल्मीकि ने मूल रामायण की रचना की। वैशाली में डेमोक्रेसी उस समय अल्फल रही थी जब विश्व के राजतंत्र की नीति विश्व की पहली राजधानी रोम को माना जाता है। दूसरी पाटलिपुत्र जो बाद में पटन देवी के नाम पटना कहलाया। अखंड आर्यावर्त का सपना देखने वाले आचार्य चाणक्य एक आम व्यक्ति के बेटे और एक सम्राट बना। हिंसा को छोड़कर जब धर्म अशोक बना तो इसे विश्व में महान सम्राट अशोक ने सराहा। और इसी के चक्र और 4 सिंह वाले प्रतीक चिन्हों को भारत सरकार ने विज्ञान, कला, संगीत, साहित्य, चिकित्सा, गणित, खगोलीय शोध, धर्म, दर्शन जैसे नए नए शोध के लिए इस धरती पर गुप्त काल में ही प्रजा को अलग अलग धर्म पालन करने की छूट थी। आयुर्वेद से दुनिया का परिचय कराने वाले महर्षि चला इसी भूमि के हैं। गर्भ में शिशु का लिंग शुक्राणु से निर्भर है। चरक ने तब बताया था जब अल्ट्रासाउंड और कैल्कुलाइट की शून्य की खोज करने वाले खगोलविद यही कह सकता है। सोचो आयुर्वेद के महर्षि और पौराणिक चिकित्सकों ने जिस समय मॉडर्न साइंस की शुरुआत की इसी धरती की याद आती है। कालिदास ने अभिज्ञान शाकुंतलम की रचना इसी भूमि से। इसी धरती ने चिकित्सा विज्ञान अद्भुत समाप्त 1925 में प्रिंस ऑफ वेल्स मेडिकल कॉलेज के तौर पर पटना मेडिकल कॉलेज को जाना जाता है। उस समय के भारत के 4 मेडिकल कॉलेज में से एक हुआ करता था। अन्य मेडिकल कॉलेज राजकीय मेडिकल कॉलेज दरभंगा दरभंगा, एसके मेडिकल कॉलेज मुजफ्फरपुर, एन मगध मेडिकल कॉलेज भागलपुर मेडिकल कॉलेज, नालंदा मेडिकल कॉलेज, एनजे मेडिकल कॉलेज जमशेदपुर, नेहरू मेडिकल कॉलेज भोपाल और इन तीनों चिकित्सा महाविद्यालय के अंकुरित चिकित्सक देश के महानगरों से गांवों तक, यूनाइटेड स्टेट ऑफ अमेरिका से यूनाइटेड किंगडम तक, कनाडा से ऑस्ट्रेलिया तक अपनी कला, विज्ञान, मेहनत, लगन और समर्पण का लोहा मनवा रहे हैं। इसी धरती ने
So good morning. I think enough delegates have come. So we are starting. So first session will be taken by Dr. Gautam N. Naik. He is a senior consultant interventional cardiologist at Apollo Hospital, Sarita, Bihar. And the chairperson of the session are Dr. Animesh Kumar and Dr. Deepak Upadhyay. Please come, sir, and start the proceedings.
Good morning and welcome to everyone in the nice scientific session which is going to start. And here is a good time to start with diabetes, where he is going to Dr. Gautam Nayak is going to speak on navigating combination therapy in type 2 diabetes mellitus. The focus on this is empagliflozin and linagliptin. So, Dr. Gautam, please start your session.
So thank you to the organizers for providing me this opportunity. A huge thanks to the BMJF Foundation. So I'm Dr. Gautam Nayak. I am a senior consultant, interventional and structural cardiologist at Indraprastha Apollo Hospitals, New Delhi. And the topic that I've been tasked for today is to speak on the fixed drug combination of empagliflozin and linagliptin. So without further ado, let me start with what the objectives of this learning exercise would be. It is to understand the scope of the problem, the pathophysiology in short, because 8 minutes are too less a time to understand all of this, but the rationale for a fixed drug combination and the clinical evidence and what we have in literature. So as we all know, the Indian scenario of diabetes, over 100 million population, approximately 11.5% are suffering, and many of them have pre-diabetics, so that's another chunk of a burden of almost 16%. So about every 1 in 4 Indians, according to this particular study as an estimate, would be suffering at least from pre-diabetic status or diabetes in the adults. Amongst Indian patients, the mean HbA1c is 8.9, which is not, or as you all know, not good control, and 2/3 of them do not achieve their HbA1c targets. We know that there's a high burden of poor glycemic control, as 62% of the patients have HbA1c levels between 7 and 8. About a third of them have this between 8 and 10, which is the concerning factor. And around 4 to 5% have more than 10. We all know the ominous octet of type 2 diabetes mellitus, which is the central dogma of this talk. And we are looking at ways and means as to how to address this problem. So as we all know, there's this octet whereby impaired insulin secretion, neurotransmitter dysfunction, there's increased lipolysis, increased glucose reabsorption in the kidneys, decreased glucose uptake, decreased incretin effect, increased hepatic glucose production, and glucagon secretion, all of which can lead to hyperglycemia. There's this talk of renal diabetic syndrome, or a metabolic conundrum, whereby problems in one as diabetes can have direct effects both on the kidneys and the heart. And it's a vicious cycle whereby increased sympathetic activity can lead to detriment in the renal function, and vice versa is also true. Landmark trials have shown us that erstwhile the teaching used to be that microvascular complications are well treated or at least delayed by good glycemic control. But recent studies have shown us that even macrovascular complications, meaning diseases of the heart, brain, and extremities, can be mitigated to a large extent by intense glycemic control, which is why we cannot overarch this principle. The cardiovascular risk is increased about twofold with increasing HbA1c levels, and 75% of all hospitalizations are due to macrovascular disease. What is the problem with conventional diabetes management? When the patient comes to us in the clinic, we initially advise them lifestyle modification measures. Then we start them on a low dose oral anticoagulant, oral hypoglycemic drug monotherapy, and then gradually up titrated. The issue with this is that there is a long time association of the duration of diabetes in someone, many of whom are detected for the first time in the clinic, vis-a-vis complications, especially macrovascular ones. So the number of years that increases, the patients living with diabetes, the time to complications is less. And this can be mitigated by very good glycemic control. So in short, there's unacceptable delays in both achieving and maintaining these goals. Long periods of hyperglycemia increase the risk of complications, as we know, and 50% already have complications, unfortunately, by the time we diagnose them. So when to initiate combination therapy? It can be considered in adults with type 2 diabetes according to the ADA 2025 to shorten time to attainment of individual goals. We can consider the RSSDI 2022 says that we can consider initiating combination therapy if the HbA1c is more than 1.5 above the target. And an entry HbA1c of more than 9, we should either consider at least dual therapy, if not triple therapy. And also in younger patients with type 2 diabetes, regardless of their HbA1c levels, in whom a stepwise approach would delay access, we can mitigate cardiorenal syndrome. What are the unmet needs in type 2 diabetes management? We do see patients with residual hyperglycemia despite monotherapy, but if we go overboard, we run the risk of hypoglycemia. There's weight concerns, and there's a failure to adequately assess cardiovascular or renal outcomes in these patients. And we need to find the sweet spot with regards to treatment. There's a paradigm shift in the management of type 2 diabetes, whereby being glucose-centric, we used to be considering A1C lowering as the primary consideration, but now we have to look at the patient as a whole, where the cardiorenal aspect and the management of complications is also taken into consideration. So the paradigm would be hit them early, hit them hard. Pillars of optimal management of type 2 diabetes. Again, as for heart failure, there are 4 pillars here. What would be broadly categorized into lifestyle modifications, risk factor assessment, pharmacological therapy, and a patient-centered collaborative approach, whereby even something like cardiac rehabilitation also fits the bill, because we need to give them an exercise plan. We need to know it has to be usually, as in the NHS, managed by a multidisciplinary team approach. Then coming back to the drugs in question, so SGLT2 inhibitors so beyond glycemic control, what are the effects that they provide? They help, as we all know, because they promote glucosuria. They lower blood pressure, reduce stroke risk. There's improved renal outcomes, as we can see, and contested reduced cancer risk, but definitely improved cardiovascular outcomes. So this is the mechanism. For lack of time, I'll not go into the details, but essentially there is promotion of natriuresis and glucosuria, whereby the long-term effects of renal and cardiovascular protection are hidden. Enhanced effects of combining 2 drugs in this is, I mean, whenever we have a fixed drug combination, the idea is to maximize the benefits and minimize the risks or cutoff. So they are complementary to each other, in that the SGLT2 inhibitors will promote glucose excretion from the kidneys, whereas the DPP inhibitors will increase the incretin hormones and boost insulin secretion. So the net benefit would be an enhanced glycemic management, reduced cardiovascular risk, and improved patient outcomes. If we initiate this therapy for someone, say at an HbA1c of 8.5, as we all know, SGLT2 inhibitors have a dose-dependent reduction in glycemic levels, meaning the more the HbA1c at presentation, the increased glucosuria, and this effect decreases at decreased dosages. So what are the clinical evidences? There's very many of them. I mean, what was studied was various therapies, or rather results were overwhelmingly in positivity with EMPA and LINA combinations. The conclusion to this was that both as add-on therapy would provide greater glucose lowering efficacy, and triple therapy should be considered. Initial combination was studied, where fixed drug combinations were thought to be better than monotherapies, and they had a 2 times higher probability of achieving HbA1c goals. Apart from that, they have pleiotropic effects, where they help in reducing body weights and changing the fasting glucose levels. The cardiovascular outcomes of EMPA and LINA are well known. The EMPA-REG outcome study was the largest such study, where they treated, the treatment arms were 10 and 25 milligrams of empagliflozin, and the secondary outcome was primary outcome plus hospitalization for heart failure. We could see that the cardiovascular death reduction was 38%, which was very high. That is seen now in subsets of patients like transcatheter aortic valves and reduction of heart failure. So the DAPA-TAVI trial has also shown us that there is improved survival. So this has become a wonder drug to the extent that if it can reduce cardiovascular outcomes or major adverse cardiovascular events by less than 38% as a relative risk, this is something that definitely should be considered. So disease survival estimates means that depending on the age of the patient, what kind of survival are you providing? So initiating this trial initiating this drug earlier in life at 8:45, you can give them a 4.5 years difference in survival. Effect of linagliptin versus placebo was studied in the Carmelina trial. About 7,000 adults with type 2 diabetes were studied. The endpoints were for time to first occurrence of composite of cardiovascular death, non-fatal MI, and stroke. The conclusion was that amongst adults with type 2 diabetes and a high CV and renal risk, linagliptin can be added to this therapy. The Carolina trial was studied to know what the time to occurrence of CV deaths, non-fatal MIs were, with the aim of establishing non-inferiority of linagliptin versus glimepiride. And the conclusion there was that amongst adults with relatively early type 2 diabetes and elevated risk, the use of linagliptin compared with glimepiride over a median 6.3 years resulted in a non-inferior risk of composite cardiovascular outcomes. Now we all know that the risk of glimepiride is hypoglycemia, but adding linagliptin or such drugs to the combination, it can also reduce the risk of genitourinary infections when combined with SGLT2 inhibitors, because it has a role in DPP4 inhibitors where the microorganisms can use any of these pathways from DPV 1 to 10, and that's a specific benefit because, as we know, SGLT2 promotes glucosuria, which is a hotbed for infections of the genitourinary tract, which limits its use, but its combination can potentially reduce the risk of this. There's reduction in risk of kidney disease progression as well, as evidenced by the EMPA kidney trial, whereby there was lower risk of GTI, as I said, and no increased risk of hypoglycemia. So this is a match made in heaven. So far, so much that the ADA guidelines in 2025 show that the glucose lowering effects of SGLT2 inhibitors are intermediate to high. And intermediate for this, but there's a sustained glycemic risk reduction in this. So the guiding principles would be in this situation is in any patient with diabetes to strive for early detection and diagnosis of type 2 diabetes, to engage with the patients to understand what their expectations are from the doctor early on in the treatment, initiate timely combinations to maximize patient outcomes, monitor patient adherence to the treatment regimen on an ongoing basis, regularly measure HbA1c in the clinic, and coordinate effectively with the multidisciplinary team, even a telephonic phone call to make sure that the patient is doing well is sufficient in most instances. Explain to the patients the benefits of early intervention. So the take-home message would be early intervention, hit them early, hit them hard. I'll leave you with a few pictures of St. Bartholomew's Hospital, where I trained in structural interventions and hopefully made friends for life. This is the largest center in all of Europe, and I was privileged to be a part of this. I am at Indraprastha Apollo Hospitals, whereby now structural therapies are becoming the norm, and I would like to thank you for your attention and have any questions. Thank you.
So thank you very much for a nice presentation. I think if one or two questions, we can just share. So it is you have presented very nicely, and these two drugs we all know that this has been recommended by the ADA, and this empagliflozin is a drug not only for diabetologists, it is a drug of cardiologists, even nephrologists, and their thing. And after coming these two drugs, I think many of the patients who needed insulin, they are doing without insulin with these drugs.
Yes, yes.
So
That's a subliminal advantage. Absolutely right, sir.
yeah. So
Yeah, that's a very good question, but a tricky one. I'm not sure I have a very witty answer for this, but I mean, based on the data, I wouldn't try and treat it any differently than any, chemotherapy induced. The only probable differences that I could see in my practice in these particular group of patients is twofold. When they have chemotherapy induced cardiotoxicities, those are the subgroups of type 2 diabetic patients that tend to do worse. If the LV function, for some reason, I mean, I don't know, it's inexplicable, but if they are doing well on those fronts, then I tend to see that their glycemic control is also better. So I don't have a scientific explanation for that.
Dr. Podar.
SGLT2 inhibitors are used in heart failure also.
Yes, sir.
So in non-diabetics, is there any chance of hypoglycemia in heart failure non-diabetics? If you are using any chance of?
Yeah, so I mean, in my practice, I haven't come across hypoglycemia due to either EMPA or dapagliflozin in patients with heart failure with reduced ejection fraction. And I haven't heard of any anecdotal reports from my colleagues as well stating that they found any such thing. So, no.
No hypoglycemia, sir. Is a GDMT is there. SGLT inhibitors is part of the heart failure treatment. Use this thing.
Yeah.
Empire or any SGLT for that matter has an advantage in cardiac. Renal is a very great advantage there.
That's why it is being used in heart failure or renal condition.
Non-diabetic. Yes, in heart failure it's a must.
Yes,
It's a
I
must.
agree.
I was trying to be polite. Yes, sir.
So thank you. If
Thank
there are
you.
no questions or comments. So thank you, Dr. Naik.
Thank you
for
so
a wonderful presentation. Now I request our chairperson to honor Dr. Gautam Naik and Dr. Mukesh Gupta to honor our chairperson. And we will start. Come this side. Now going to the second session, that is by Dr. Peter Pankaj, and the chairpersons are Dr. Hemant Govil, and I request Dr. S.K. Podar, please come on the dais as a chairperson for Pritam Pankaj. Please come. And the topic is importance of moisturizer in dermatology.
Uh, Next speaker our is Dr. Pankaj, Pritam Pankaj. Dr. Pritam Pankaj done his MBBS from Bangalore Medical College and MD from Patna Medical College. At present, he is working as a senior consultant dermatology, Skin Karma Dwarka, and Chandrasu Skin Clinic, Mohan Garden, and Mata Chanan Devi Hospital, Janakpuri. Welcome, Dr. Pankaj.
Thank you, sir. मैं थोड़ा सा इसमें सुधार करूंगा. Importance of moisturizer in not in dermatology, in total. कोई भी ऐसा ब्रांच नहीं है जिसमें मॉइस्चराइजर की ज़रूरत नहीं होती. चाहे वो डर्मेटोलॉजी हो, मतलब डायबिटीज हो, थायराइड की समस्या हो, रीनल फेलियर वाले पेशेंट आ गए, यूरोमिक प्रोराइटिस हो गया, आई मीन प्रेगनेंसी हो गई, नियोनेट हो गया, इन्फेंट हो गया, एटोपिक डर्मेटाइटिस बच्चों में कॉमन होते हैं. तो आई विल ब्रॉडन ए बिट इम्पॉर्टेंस ऑफ मॉइस्चराइजर. Moisturizer is not dermatological word. Basically, moisturizer is used first time by marketing people. So this is word by marketing people. But in dermatology, this is oleaginous material which is used to make the skin softer. So it's basically moisturizer is used for dryness of skin. So overall percentage of dryness in the world population is 29 to 85%. So this is, you can see the burden of drainage on. There are so many diseases which is there where dryness is there. So most important is atopic dermatitis. We keep on seeing it. We keep on listening from the childhood to adult, airborne contact dermatitis. So psoriasis, ichthyosis, these are the common dermatosis which is got there. So when you have dry skin, it will impact the quality of life because dry skin will